Good afternoon. Me and my colleagues are here today to discuss Indigenous maternal health outcomes in Canada. As you guys will be future nurses, it's our responsibility to look beyond clinical charts and understand the systemic and historical factors shaping the health of Indigenous mothers and their children. Our session is going to follow this roadmap to meet these three core goals. One is identify the disparities in health care access and mortality, analyze how colonialism and geographic barriers create these inequities, apply these insights to a case study on culturally safe nursing care. Let's start by looking at some data. The gap in healthcare access is very stark. While 97% of non Indigenous mothers have a regular provider, that number drops to 48% for Indigenous mothers and only 29% for Inuit women in remote areas. Because consistent care isn't accessible, many Métis and First Nations women are forced to rely on emergency rooms or report that their needs aren't being met at all. These aren't just statistics, they represent people being failed by a system that wasn't built for them.
The perinatal health outcomes speak for themselves. Indigenous women face twice the risk of maternal mortality. Indigenous infants are 2 to 4 times less likely to survive infancy, and rates of sudden infant death syndrome are 7 times higher. Higher rates of preterm birth, low birth weight, and stillbirth round out a picture of a system that has consistently failed Indigenous women and their babies. This diagram shows how maternal mortality is shaped from upstream to downstream factors. At the top are systemic factors like colonialism, including residential schools, the 60s scoop, and ongoing racism in healthcare, which create the foundation for inequities. These then influence social determinants of health, such as poverty, housing, food insecurity, and limited access to culturally safe care, especially in remote communities. All this leads to downstream clinical outcomes like higher rates of diabetes, infections, stress, and pregnancy complications. This goes to show that maternal mortality is not about individual choices, but the result of these precipitating factors.
Understanding both emic and etic perspectives help us understand behavior and culture, especially in Indigenous maternal health. So from an emic perspective, birth is just not a medical event. For many Indigenous communities, it is a cultural, spiritual, and relational experience that involves family, community, and elders. Because many Indigenous women must travel over 1,500 kilometers for maternal care, they are separated from the support system. Before colonialism, Indigenous women gave birth in their own communities with the help of midwives, relatives, and traditional knowledge. Indigenous midwifery still plays a vital role today, carrying cultural teachings and practices. However, mistrust of hospitals rooted in racism, stereotyping, and past harms continues to affect Indigenous women's experiences and increases risk during pregnancy. From an ethnic perspective, healthcare providers often view birth primarily as a medical event that requires hospital care. The biomedical model focuses on procedures like C-sections, epidurals, and continuous monitoring. In this approach, cultural, emotional, and relational safety are often overlooked. Indigenous practices may be dismissed or not included in care, which can create culturally unsafe experiences for Indigenous families.
In terms of systemic factors, a big issue is that many indigenous communities are in rural or remote areas where healthcare isn't easily accessible. Because of that, pregnant individuals often have to travel long distances or even leave their communities to get prenatal care or give birth. This isn't just about distance, though. There are also systemic issues like limited resources and gaps between federal and provincial care, which makes access even harder. All of this can disrupt care, increase stress, and reduce feelings of safety when care is far from home. In the end, it leads to less consistent care and higher risks for complication during pregnancy and birth. Building on that, colonial policies have also shaped how maternal care is delivered. Instead of community based, culturally grounded care, the system often follows a Western medical model. One example is evacuation for birth, where pregnant individuals are required to leave their communities weeks before delivery to give birth in urban hospitals. This means being separated from family, culture, and support systems during an already vulnerable time. It can create a lot of stress, make care feel unfamiliar or even unsafe. Because of this, many individuals feel a loss of control and trust in the healthcare system, which can lead to less engagement with care.
Overall, the recommendations our group is calling for aren't abstract policy ideals, but they are the minimum of what Indigenous women deserve. At the downstream level, we're calling on nurses, ourselves included, to do more than tolerate traditional knowledge in care settings. We must replace top down biomedical interactions with mutual knowledge sharing, actively inviting Indigenous knowledge into the care relationship and centering it, not just acknowledging it. At the midstream level, we need to fund and expand Indigenous led midwifery and Indigenous patient advocates initiatives. Organizations like Community Midwives of Toronto show us what community based and culturally grounded care actually looks like, and it demonstrates that birth belongs in the community, and our funding structures need to reflect that. At the upstream level, routine obstetric evacuation separates Indigenous women from their families and cultural support during one of the most vulnerable moments of their lives, which compounds trauma rather than reducing it. Therefore, governments must reform these policies so that evacuation is a last resort, not a default. The bottom line is this: reconciliation doesn't start with the government, it starts with us. It starts with every nurse choosing to center Indigenous women, their knowledge, and their voices at every level of care.